going to talk about the inflammatory response. Over here in the board, I've drawn out some tissue cells. Right, this would be like the skin, and I drew a nail coming down into the skin, right, and a blood vessel down here, and a couple of immune cells that you have that lie right under the skin. Mast cells, but mast cells and dendritic cells. Right? They lay right under the skin and wait for pathogens to come in so that they can start the immune response. So the nail comes down into here and damages some of these cells. These cells here release some cytokines. Let's make these purple. They release some cytokines. So one thing these cytokines will do is they will activate this mast cell. This mast cell is full of histamine. Let's make histamine green. Boom, 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 boom. Right? And it will release histamine out into the area. What histamine does is it will cause the blood vessel here to vasodilate and to get more leaky, right? And I'll just kind of draw that in here. This is the blood vessel. Let's kind of draw this here. You can see that this blood vessel here has dilated now, and so it's going to be able to hold more fluid in it, right? So more blood can fit into that area. And we've called for more white blood cells to come. This dendritic cell here will also, if there's any pathogens on this nail, which you can guess there are, when you step on a nail it's not usually sterile. So the pathogens on this nail here will be here in the interstitial space, or maybe even down in the blood. But anyway, the dendritic cell will pick those up and carry it to lymph nodes. And so when it gets to the lymph nodes, then the lymph nodes will start start a response of its own that I'm not really going to talk about here. So anyway, now we've got histamine being released right into the area. We've got some vasodilation and permeability, and these white blood cells are called to the area. Boom, get these white blood cells coming. Another thing that gets called here is some platelets. Let's make our platelets blue. Right? So let's put some platelets in here. Right? Because this guy here is also activating the clotting system. So, right, because that nail gets pulled out, you don't want to be bleeding to death, right? So you need to activate the clotting system. So so now what we got here, we've got vasodilation, vessel leakiness. So now these white blood cells that got called to the area, more of them can fit in here because of the vasodilation, and the leakiness is going to cause it so that these white blood cells can get out here and they can eat up whatever pathogens might happen to be there, might have come in on that nail. Now they're going to be able to go ahead and attack pathogens in the interstitial space, because the whole goal is to keep those pathogens out of the blood. You want to get them while they're in the interstitial space, and if they're in the blood, you want to get them right away, right? And so when I talk about the vasodilation here, so that more can fit, you also have vasocontraction downstream. So that way this blood can't, these pathogens that do get in the bloodstream aren't going to be moving down into the vasculature. They're going to be held right here so that all these white blood cells coming into the area can get them before they go systemic. What kind of symptoms are we going to have? Increased circulation to that area, right? It's going to cause redness. You've got more blood coming in there. Warmth, because you got more blood coming in there. Edema, because you've got all this tissue squeezing out here. Another thing too is that some of the proteins will leak into that interstitial area and will raise the osmotic balance and actually pull more fluid into that spot. So you're going to really get some edema here and pain. A lot of these chemokines that I talked about, or cytokines, are going to stimulate the nociceptors, which are pain receptors, and cause pain. and the pressure of that edema is going to cause pain. Okay, so when we're talking about the inflammatory response, we got to remember we're talking about vasodilation, we're talking about the vessel leakiness, and we're talking about setting off the cascade for blood clotting. So those three things happening, that's great, you know, when I hit my finger or cut my finger and I want to fight any pathogens that might be there, and you get the little swelling in my finger or wherever, you know, you happen to have an injury. But what happens when this goes systemic? You get these inflammatory messengers all over your body, right? Maybe the pathogen is such that it went in and got into your bloodstream and went all over your body and you've got it all over. Or maybe it's just set off the inflammatory response, right? All over the body. So what you're getting now is you're getting vessel dilation all over your body, vessel leakiness all over your body, and clotting all over your body. So that's going to lead to a lot of problems, like you'll see here in a few minutes as I get talking about this. So first of all, you get systemic inflammatory response syndrome, right? So systemic inflammatory response, that tells you exactly what it is, right? You're getting an inflammatory process, or you're getting inflammation everywhere, right? So you're getting this vessel dilation and everything everywhere. So vasodilation, what's that going to do? You got vasodilation of your little vessels, right? Your little vessels turn into big vessels, right? All over your body. Drops your blood pressure, right? You also get fluid shifts, so you're going to lose some of your fluid off into the interstitium. So your vessels become more leaky, so the fluid shifts out of your vessels and into the interstitial spaces, right? Into the interstitial areas in your tissues. So now you've got a loss of fluid in your vascular system, and your vascular system has gotten bigger, right? So that's really going to decrease your blood pressure. And if you get clotting all over the place, you run out of clotting factors, and you end up with DIC, disseminated intravascular clotting, which means that you got clotting all over your system. You run out of clotting factors, and now you're at risk for massive hemorrhage, right? And you'll start seeing petechiae. Petechiae, little red spots all over. That's because the blood is just leaking through your vessels, right? You got the blood leaking through your vessels all over. A lot of times you see it right down here around the neck. I see it on the forehead, right? Now I'm going to talk about septic shock. You can think about what septic shock is just by that name. Okay, so when you think about septic shock, just take that apart. Septic, right? Dirty, like a septic tank, right? So infection, septic, shock. So you're going into shock. What's shock? Shock kills, right? I like to say that. Shock kills, because whenever you hear that something is causing shock, you can figure it's very, very serious. Shock is always, no matter what kind it is, it's always a lack of perfusion. When your blood pressure drops to the point where you can't perfuse your vital organs anymore. Right? Your mean arterial pressure should stay over 60. If it gets down close to 60, you got to be careful, because you don't want to cause that to drop. I mean, you would never give somebody with a mean arterial pressure in the 60s something like Lasix or something, because you're going to drop their fluid, and you're going to drop that mean arterial pressure even more. When I say mean arterial pressure, what am I talking about? I'm talking about the pressure created from your heart in the arterial and then down into the arterial capillary system. We all know what a blood pressure is, right? You got your heart here. Your heart pumps out. Let's just say that's your aorta that's coming out there. Every time it pumps, it sends a burst of blood out into the arterial system. Boom. And that ripple, right? Every time it pushes, zoom, it just boom, and it sends those ripples out. That increased pressure just bursts that pressure out there. And you can feel those ripples, right? You take your pulse, that's what you're feeling. You're feeling the ripples created by the heart as it beats. So if you got a blood pressure of 120 over 80, you can figure, okay, the 120 is the pressure that you got in here, in that ripple. And the resting phase is where your 80's at. And I did not draw this really anywhere near to scale, so I'm going to try to make it a little bit more to scale. Right, 120 in there, 80 in here. And the reason I said I was going to make it a little bit more to scale is because your resting phase, your diastole, which is the resting phase of the heart, is twice as long as your systole, which is the time that the heart is beating. So now what your mean arterial pressure is, your MAP, right? What that is it's the average pressure, and that's the pressure that you can figure is down there in the capillary beds that you need to perfuse into the tissues, and that is the average of these numbers. Now normally when you get an average you just add 120 plus 80 and divide it by 2. That's not what you do here, because you got twice as long in diastole as you do in systole. Boom, 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 boom. Right? So you got twice as long in diastole. So what you have to do is you go 120 for your systole plus 80 plus 80, then divided by 3, because 1, 2, 3. So let's see what that is. 120 plus 80 plus 80 equals 280 divided by 3 equals 93. It's 93.3333 or whatever, but so you got a mean arterial pressure. If you have a blood pressure of 120 over 80, your mean arterial pressure is 93. That's a good mean arterial pressure, right? You don't want that mean arterial pressure to get below 60, because then you'll be failing to perfuse your major organs. Go into MODS, multiple organ dysfunction syndrome. Right. So what can drop that? What can drop that map? In other words, what's going to drop your blood pressure? Right. There's several kinds of shock out there. We're talking today about septic shock, which I will explain how that happens. But you got cardiogenic shock, right? When we talk about myocardial infarctions, they lose that cardiac output. You go into cardiogenic shock because you're not getting enough pressure out there to perfuse the vital organs. You end up in shock. You can go into hypovolemic shock. Let's say you've been in trauma and you're bleeding all over the place, either externally or internally, and you're losing this blood, and so you end up in hypovolemic shock. You can have an allergic reaction, go into anaphylactic shock, which is a chain reaction and causes vasodilation all over the place. Right? So you get these problems from several places, but how does an infection cause shock? Well, like I was saying, you got the infection, you get the vasodilation, vessel leakiness, right? And that happens all over your body. Boom, your blood pressure drops, you go into shock, right? So you're not perfusing well. And by the way, something I want to tell you here. What's something that you do really quickly that you can do for this? Something that you might not think about, but a real quick thing, put this guy on oxygen. It's a real easy thing to do. You're not perfusing well, at least you can make it so that the blood that does get into into the tissues is oxygenated as well as you can have it oxygenated. Real simple thing, something that you do right away. So what are some common culprits? Right? What are some things that cause shock? Well, any infection that goes systemic can cause shock. But one thing is, a person is vulnerable to shock if they have a decreased immune system, right? Now you might think, well, it's the immune system that's causing the problems. Yeah, it is. But if you're not able to respond appropriately and wipe out a pathogen before it goes systemic, you're going to end up in shock, right? So when your immune system is compromised, you very likely can end up in shock. And some pathogens are more likely to cause shock than others. They're either more likely to get into the system or more likely to cause a hyperactive response by the immune system because it releases what we call super antigen exotoxins. In other words, something that's going to really cause your system to start releasing a lot of cytokines, which will cause a lot of white blood cells out there, which will cause this systemic inflammation. Some common infections that start out just basic infections, don't seem like a big deal, but they can end up going systemic. UTI is one of them. urinary tract infections, especially on an older person, especially on somebody who's immunocompromised. Peritonitis. That's why we worry about peritonitis so much, right? You get an appendix that bursts, right? You get peritonitis. It's a real big problem because it can very easily lead to shock, right? Because it goes systemic and boom, it's all over your system and you go into shock. And by the way, shock kills, right? I think I've said that. I'll say it again. Shock kills. It's a very dangerous thing. Most of the time when you die from something, it's actually the shock that resulted from the problem, right? You die when you have an MI, it's because you didn't get the cardiac output, you ended up in cardiogenic shock. Another one is pneumonia. Pneumonia is a common cause of shock. So let's look at the process of sepsis and septic shock. You get the vasodilation, leads to a drop in blood pressure. Plasma shifts into the interstitial spaces, out of the blood vessels, into the interstitial spaces. Also leads to a drop in blood pressure. And remember, we want to be able to maintain a mean arterial pressure of 60. A decreased perfusion leads to multiple organ dysfunction syndrome. So that means that the tissues are not getting enough blood. What does that mean? It means they're not getting enough oxygen. In order to create the energy to function, your cells have to resort to anaerobic metabolism. Now what's the problem there? If you remember right, I don't know if you've seen any of these videos before or if you've had me in a classroom, but I very often bring this up. Your cells need two things to burn clean. And when I say that, burn clean, what the hell do I mean by that? Well, I like to give an example of, let's say you got a wood burning stove. And in that wood burning stove, you like to put a big chunk of oak wood, some nice hardwood. It burns slow and it burns clean. Your house doesn't start smelling like smoke. Yeah, if you run out of that and you have to put an alternative like some pine or something soft, it burns fast. You got to keep sticking more in there and you get a whole lot of smoky smell out of it, right? It doesn't burn clean. Well, your cells, think of them as having a wood burning stove in there. You want them to burn clean, right? In order to burn clean, they don't use oak, obviously. They're not going to use oak wood, but they will need the right materials to burn clean. They need glucose and they need oxygen. If they're missing either one of those, they can alternatively get some energy through alternative fuels or anaerobic metabolism, but they will not burn clean and you will be acidic. That's the way I like to think of it. Easy way to think of it. So if they're missing glucose, they go into ketoacidosis, right? Because they burn alternative fuels, they end up with ketones, right? And if they're not getting oxygen into the cell, well, anaerobic metabolism, lactate is a byproduct of anaerobic metabolism. You go into lactic acidosis. So ketoacidosis from lack of glucose in the cells, lactic acidosis from lack of oxygen in the cells, right? Both of those things will lead to an acidosis. So now we are having a lack of perfusion. We are not getting our oxygen into those cells. They very well are going to end up in lactic acidosis, so they're in metabolic acidosis, right? That's a problem. Your hormones don't work right. Your enzymes don't work right, right? You need that pH in that narrow normal range of 7.35 to 7.45. Gets into the acidic range, right, below 7.35, this person's going to have a lot of problems. Now, when we're talking about shock, a lot of similarities, right, because we're always talking about a lack of perfusion. However, one good way to figure that this might be septic shock would be if the person is failing to clot well, or if they're going into disseminated intravascular coagulation, right? They've used up all their clotting factors, and they're not clotting well. You can figure this is probably a septic shock that this person's in, right? You've usually got somebody laying there that can't do anything if they're in shock. Believe me, they're sick. And what you'll notice, right? You know, you put these IVs on their arm, and you put that occlusive, transparent occlusive dressing over it, right? She's got that transparent dressing there. You look there, and a lot of times they'll leak around that. Might be the first thing you see, even before petechiae. You'll see that it's leaking around the IV site, any kind of traumatic area, right? You don't want to give them an IM shot, right, because they're just going to bleed like crazy. Another thing is, problem that you get with sepsis is ARDS, acute respiratory distress syndrome. And what goes on there is you get inflammatory response in the alveoli of the lungs. Right? That's how we like to diagram the alveoli. And you got the blood coming in, then it gets oxygenated, and then we'd like to draw it as red, just to show that it's oxygenated now. So what happens in sepsis is you've got all these cytokines, these inflammatory messengers, they come in here, right? They're out in the body, they go up to the right side of the heart, they get pushed into the lungs, they get pushed into those lungs, and boom, they hit that capillary beds, and they all get down in there, and they start, and that slows them down. And now they start calling more of their friends to the area, right? Because that's what inflammation does. It vasodilates and makes the vessels leaky. Vasodilates these capillaries and makes them leaky. So now you're going to get fluid shifting into here, right? Your fluid shifts in there. The alveoli can't expand very well because you're getting edema in between there, right? So now your alveoli is like this, right? Every time you inhale, that thing's supposed to blow back up into that nice little ball there, but it can't because you got all this fluid in here, right? And then we know that towards the end of ARDS, you've got all this inflammation. One of the final things that happens in inflammation that I didn't really talk about earlier was scarring, right? Trying to seal things off. And so that's what happens. You end up with scarring in the lungs, fibrosis in the lungs. So sepsis leads to ARDS, which leads to possibly permanent pulmonary problems, right? Permanent breathing problems. You know, so it shouldn't surprise you when I tell you that 50% of the people with sepsis and going to septic shock die. There's a lot of problems that happen from sepsis. It's a very serious diagnosis. I want to talk about MODS, the multiple organ dysfunction syndrome. Probably the main thing, the first thing that you're going to see is a problem with the kidneys. Because of that, you always want to put a Foley catheter in these people so you can catch it if those kidneys stop working. You want to see that that person's making urine. When they get ischemia, which means lack of oxygen, and they get that lack of oxygen coming into their kidney, those nephrons, there's 1 million nephrons in each one of your kidneys. And those guys have lots of little pumps and stuff. They need oxygen. Those pumps, right, their symptomer pumps and everything that they got in there, they take energy to run, right? It's not diffusion or osmosis or any of that. It's active transport, right? They need the oxygen. So when they stop getting it, that's one of the first organs that you will see. It probably is the first organ that you're going to see fail, is your kidneys. So you want a Foley in there to make sure that person is still making urine. And so if they start losing nephrons, they can get acute kidney injury. When you don't have your kidneys working, you're not regulating your fluid and electrolytes, right? Your electrolytes get thrown off, your fluids, right? You're not doing that right anymore, right? You're not taking care of it. You're not releasing renin for the renin-angiotensin-aldosterone system. Your kidneys can fail to release epopoietin, right? That epigen, and if you don't have that, then you're not going to be making your red blood cells. When you run into the problem with your kidneys, that you run into a lot of different problems, and a big one too, your acid base. I already talked about the fact that you're in lactic acidosis. Your kidneys are supposed to be trying to save their bicarbonate and make more bicarb. They can't do it because they're failing, right? So they can't do the compensation that they're supposed to be doing for this acidosis. So the acidosis just gets even worse. And you know, when I was talking about ARDS before, you get this big buildup here, you end up with what we call shunting, right? It'd be like a physiological right to left shunt, which is, you know, whatever. It just means that the blood is going through here, but it's not getting oxygenated, right? You can put this person on 100% oxygen, doesn't improve them. Doesn't matter that they breathe in 100%. It's not getting in here. It's not getting into the blood. So they have what they call refractory hypoxemia. Refractory hypoxemia means that the person does not respond to oxygen. You put them on 100% oxygen, they stay about the same. Now, another thing is when your liver fails. That's a big problem. Your liver detoxifies things. It makes it so that you can get rid of things. Another thing that your liver does is it makes proteins, puts things together, right? So it makes albumin. So when the liver fails, you don't have the ability to detoxify things, right? They're supposed to be breaking things down and turning them into things that we can get rid of. You lost that ability. Plus you lost the ability to make albumin. And albumin is important in maintaining your osmotic balance. So you've lost that ability too. All right, so what's this person going to look like? Well, they've got vasodilation, so they're probably going to be warm feeling and flushed. They may very well be in respiratory distress and decreased urinary output if they're not perfusing the kidneys. Right? So these are some things that are going to happen. There also will probably be they will at least have a change in mental status. They will probably be confused or even unresponsive. And so what lab values do you want to do? You want to get blood cultures, and you get those blood cultures before you've given any antibiotics, because of course when we talk about treatment, we're going to be talking about antibiotics, but you want to get blood cultures before you've started antibiotics, because antibiotics kill the germs, right? And if you're killing them with an antibiotic, you can figure it's going to alter the results of your cultures. You want to do a serum lactate. Remember I said when you get a lack of perfusion, the cells resort to anaerobic metabolism. A byproduct of anaerobic metabolism is lactate. So lactic acidosis is a problem that you're going to get with that, and so you're going to check their serum lactate and see if it's elevated. You're going to check their BUN and creatinine because you want to see, are their kidneys working? BUN and creatinine, or what do you do to check your kidneys? Of course you're going to check a CBC, see where that white count is, right? There's two things that you can expect with your white count. Super high white count or a very low white count. This is such an extreme response that your system will run out of white blood cells. It just can't make them fast enough, right? So then what happens is you're going to see an elevation in band cells. That's an immature white blood cell, right? Because a white blood cell, right, a segmented white blood cell, well, it has little segments. And when it's a band cell, it's smooth, right? It's a baby yet. It hasn't developed the segments yet. So you're going to see an increase in band cells. Makes sense, right? Because can't keep up, so it's making a whole bunch of them, so there's a whole bunch of babies out there, right? But they're not a whole bunch of mature ones. You're going to see a higher percentage of band cells than what you should find. Another thing, you might run into high temperature, and you might run into a very low temperature. When a person is actually going into shock, they lose the ability to regulate their body temperature, and their temperature can go really low, right? Below like 96.8, I think, is a criteria for. And you can expect the respiratory rate to be high. They're going to be breathing fast, or see their CO2 level on an ABG will be low, right? And they decided that they call it septic shock when they don't respond to a fluid challenge, which I will talk about in just a minute. The last part, after you've gone through, right, you're in sepsis, then it gets more severe and you end up in septic shock and you end up with MODS, and then very often death. So how are you going to treat this person when they come in? You're an emergency room nurse, how are you going to treat them? Well, you're going to try to get 2 large bore IVs, at least 1 large bore IV and then 1 regular IV if they're really a hard stick, because you're going to have to be giving them a lot of fluids. You're going to give them a fluid challenge, 30 milliliters per kilogram of IV fluid, normal saline. And remember, the sooner you can start treating them, the better. Then you're going to push that fluid in, and you're going to get an antibiotic going on them. You always, when you stick those large bore IVs in, draw a couple of blood cultures, because you need those blood cultures drawn before you start the antibiotics, and you want to get the antibiotics started as soon as possible. So your treatment will focus on decreasing hypoxia, maintaining an acid-base balance, keeping blood glucose levels normal. Now, I haven't really talked about that, but anytime your system is stressed, your system will release cortisol, and also very often the sympathetic nervous system is going to kick in. Both of those things, part of their function is to increase your blood sugar, right? You need that increase in blood sugar in order to handle the stress, right? Release cortisol if you're going into a stressful situation. You want that blood sugar there all ready for your muscles and everything to use it when they need it. So increase in blood sugar is part of that stress response. Your system is stressed, you're going to have a really tough time controlling their blood sugar. And you want to maintain their blood pressure, right? You want to keep that perfusion. You want to able to perfuse your major organs. And you very well might be given some low-dose corticosteroids, right? Even though your system might be releasing them, you might give a small amount of steroids so that you can, because they can cut down on the amount of inflammation going on in the whole body, and that's kind of the culprit of the whole thing. Blood sugar is tough, insulin drip, right? You're going to hang an insulin drip. If the blood sugar is really up there, you're going to hang an insulin drip. You can be expecting to have an order for an insulin drip. You want to keep this person oxygenated. If the person is not breathing efficiently, you're going to intubate them, right? They're going to be intubated, you're going to breathe for them. If you can, you might be able to put a BiPAP on them, you might be able to just get by with putting oxygen on them, but you got to keep them oxygenated. We're going to be starting antibiotics, right? You get them blood cultures drawn, you're going to start some broad spectrum antibiotics, something that kind of kills everything but isn't like real good at anything. So you'll start that. When the blood cultures come back in a day or two, it will have a culturing sensitivity, so you'll see what the bug is and you'll see what it's susceptible to, and they will tweak what they're giving them. They might change the antibiotic to something more specific to do a better job at killing that specific bug. And remember, if the blood pressure does not respond to the fluid challenge, they're considered them in septic shock, and you're going to give some pressors on them, right? Some vasopressors to try to bring their blood pressure back up. Make sure that you get these vasopressors going if they are going into this septic shock, right? In other words, if their cardiac output is dropped, right? They're going to get some vasopressors. Norepinephrine, vasopressin, which is a synthetic ADH, antidiuretic hormone, right? So we know how that works. We've gone over that several times. Or dopamine. Right? Dopamine seems to be one of the common ones, right? But you're going to use some of these medicines to try to bring their pressure back up. They'll clamp down these, they'll cause vasoconstriction, and hopefully will bring that blood pressure up. All right? So we talked about some of the initial labs that you're going to do, right? The lactic acid, the blood cultures, CBC, right? BUN, creatinine, right? You're going to do those things, but and you get this person, they don't get better overnight. They're going to be in a hospital bed for a couple of weeks. So you're going to end up monitoring the progress, and what you can expect to see there is some of the inflammatory markers, the CRP, C-reactive protein. That should be less than 1, right? So you're going to look to see. Now it'll be really high, and you're hoping that it's going to come down, right? So you're hoping that that CRP will come down. The other one is the SED rate, the ESR, and you want that to be less than 25 millimeters an hour, right? So CRP less than 1, ESR less than 25. Those are two different tests that kind of tell you the same thing. I don't really know all the specifics on how they work, but I just know that you're going to watch those levels, and you're hoping that that amount of inflammation drops, and you will be able to see that with those two labs.